A very good evening to all of you. I welcome you to the seventh series of the Asian Cardio-Oncology Society conference today. And today we have with us Dr. Devi Shetty, who is the chairman of Narayana Health Group and a senior cardiosurgeon. Sir has been very kind to accept being the patron of Asian Cardio-Oncology Society and has taken out time from his busy schedule to grace us today. So, without much ado, I would request Sir to just give us a small patron's address and a few guiding words regarding how we should go about this Asian Cardio-Oncology Society that we have formed and to introduce our keynote speaker today. Thank you, sir. Over to you, sir.
Thank you so much, Vivek. I'm extremely grateful to you for giving me the opportunity, and I'm looking forward to just express my views about the path you have chosen. First of all, I have a special interest in addressing all of you because of my personal experience in this area. My one of my very close relative, I don't wish to say how she is related to me. She was not even 60. She was diagnosed with cancer of the breast, and she received the appropriate treatment, and she recovered extremely well. About few months after the chemotherapy and her entire treatment was over, she started complaining of shortness of breath. And obviously, they talked to me, and I asked them to get an echocardiogram done. And her ejection fraction was 20%. And she had normal cardiac function just 1 year before the whole episode of treatment. The oncologist did a fantastic job in curing her from the cancer because it's nearly 10 years now. She's fine, but her ejection fraction is still hovering between 20% and 30%. Her quality of life is ruined. A lady who could have otherwise enjoyed the last 10 years of her life is virtually reduced to hovering around the house. Now, I'm not blaming anybody because, as I said, they have cured her breast cancer, but whatever be the reason, she is left with a crippled heart. And she's not the only lady having this problem. We come across, we have very active cardiac transplant program. We see so many women, so many men suffering from cardiomyopathy following treatment of the various types of cancers. And also, we see very large number of patients suffering from cancer of the heart, which was earlier thought it wasn't very common. We have seen all kinds of renal tumors getting into we do very large number of pulmonary endarterectomy. We have at least 10 patients out of our series of close to 700 pulmonary endarterectomy. At least 10 patients had some type of a tumor. Most of them, it came from renal tumor. When we did the pulmonary endarterectomy, we didn't even know that the patient had cancer of the kidney. And when the histopathology report came, when we looked back, it was cancer of the kidney. So essentially, there is a very close relationship between these two areas. We wouldn't have come across all these problems in the past because number of patients seeking treatment for cancer and heart was very small. Even now it is very small, I can tell you that. Compared to the number of patients who suffer from the disease, number of patients cardiologists and the oncologists treat is extremely small compared to the number of patients. but it is going to change. It is going to change dramatically because of virtually every government hospital, every medical college hospital insisting on having a CT scan, MRI, ultrasound. Earlier, we had limitation of people who are doing those tests. Of course, we still have less than 10,400 radiologists who are qualified to certify a ultrasound report. But then, in the process, we have trained large number of technicians who are very good in doing the ultrasound of the abdomen or the heart, and the radiologist sitting in remote locations is signing off those reports. So, in the process, in the next 10 years, all of us will see huge number of cancer. And more than anything else, we are going to see early stage cancer. We are going to see early stage heart problem because technology will dramatically change everything what we see as the way patients present themselves. Our biggest problem why people do not seek medical care at an early stage is because of the difficulty in seeing the right doctors. Because most of the doctors are living, especially specialist doctors, are living in big cities, and 20 kilometers away from the big city, you don't even find a basic specialist. So, but this is going to change with all these telemedicine and the various applications which will be developed on the mobile phone. When somebody gets tummy ache, which keeps on going for more than few days, if he's fed up of the local doctor with the way he is treated, all they have to do is to, with touch of a button, they get to see the top gastroenterologists of the country online. They can see the top oncologists of the country online. And this is already happening today in my practice. I see at least 20 to 30 patients every day online. I see as many patients in front of me as I am seeing them online. And it's going to catch up. When that happens, if somebody has a painless ulcer in the tongue, which has been going on for quite some time, all they have to do is to open their mouth, and a dentist or a medical oncologist or a surgical oncologist on the head and neck surgeon on the other side can see the lesion, and he will direct advise the patient to go for a biopsy. So we are going to see huge number of patients with both the problems. And as we see more number of patients, we are going to see a lot more complications. And my sincere request to all of you is that the ECG interpretation using analytics are revealing unbelievable things. They are predicting cardiomyopathy 1 year, 2 years before the cardiomyopathy happened. So if your consortium, you all get together and collect the patient's ECG, all patients undergoing chemotherapy, you collect the ECG, let the analytic tool study the ECG, and the same patient at regular intervals, if they have ECGs, our naked eye may not be able to find the subtle change, but the analytic tool will find the subtle change. And this is the way we may be able to detect early stage of cardiac injury due to chemotherapy or radiotherapy or whatever before it is too late. And every standard of medical care today is defined by US and Europe. We have to change. We are not Americans, we are not British. Our body is different. How we respond to the treatment is different. Our diseases are different. We have to produce our own standards. And with all of you enthusiastically coming together to create this society, I'm sure in the years to come, you will redefine the way Indian patients are treated with the oncology related to cardiac problem. Thank you so much for the opportunity. Good luck and God bless.
Sir, would like to again request you to introduce our keynote speaker.
Hello.
Yes, sir.
Yes. Yeah. Thank you. Thank you very much, Dr. Arjun Ghosh. Thank you so much, Arjun. I read something about you in the past, I'm happy that you are here, and we will be definitely more enriched with your advice on cardio oncology, the area. Thank you so much for the opportunity.
Thank you so much, Devi sir. Now hand it over to our keynote speaker, uh, Dr. Arjun Ghosh. Over to you, sir.
Uh, Thank you so much, Dr. Shetty, for that very kind introduction, and thank you to the organizers of the ACOS for this opportunity to speak today. So my talk today will be on the cardiovascular effects of CAR T cell therapy. I have no disclosures. Um, so what I'll be doing in the course of this talk is explaining what is CAR T therapy, what are the current trials, and what are the commercially available products. I'll talk about potential cardiotoxicity. I'll talk about cytokine release syndrome, the management of this toxicity, and about patient pathways to minimize toxicity. And I'll illustrate this with a case from our center. So, CAR T therapy may be new to a lot of people. I know that there are some centers in India where CAR T therapy is coming in, but let me just give a bit of explanation. So, CAR T is a chimeric antigen receptor, and this has really been a new therapy, new emerging therapy against hematological malignancy. And this just shows the timeline of the development of this new therapy. So back in the 90s, the engineering of this took place, and then the first generation of cars were developed. And over the course of the subsequent 20 to 30 years, it has now become a commercially available product. So what is CAR T therapy? A CAR is a recombinant fusion protein, which consists of the variable portion of an antibody or a single chain antibody variable fragment. And what it does is it can activate T cells upon the recognition of a specific antigen. And this antigen lives on the surface of the tumor cells. And then with the activation, this results in the death of those target tumor cells. Now, CD19 is often a target for the CAR cells because this is expressed throughout the B cell lineage and is highly expressed on the surface of most B cell tumors. And CD19, importantly, is not usually found on normal tissues, such as in the heart. Now, we had lots of different generations of CAR cells, as I showed in the previous diagram, and this is just a kind of cartoon to show the different generations developed over the course of time. Now, how does a CAR T cell work? So as I mentioned, the CAR T cell recognizes an antigen on the surface of the tumor cell. And after that, there is immune cell activation, there is a cytotoxic activity, and there's also proliferation of the body's normal immune system to fight against the cancer cell, ultimately causing cancer death. Now, the whole point of this talk is to try and develop research collaborations and try and develop thinking, across Asia. And let's have a look at where the current trials are taking place. Interestingly, the #1 site worldwide for CAR T trials is actually in Asia, in China. Thereafter, it's America, and then there are a number of centers throughout the world. Unfortunately, as far as I'm aware, there are no current CAR T trials taking place in India, but hopefully with educational activities like this is something that we can change. Now, what are the malignancies that are targeted? So you'll see from this pie chart that the majority of the malignancies are lymphoid malignancies, such as lymphoma, leukemia, CLL. There are also some solid tumors, myeloma, and interestingly, this therapy is also being trialed in HIV and SLE. The majority of the agents the trials are against single antigen targets, but as you'll see from this chart, there are some trials where the CARs are against multiple antigen targets. And you can see on the right-hand side, the number of trials in this area is exponentially increasing. So what are the current commercially available CAR T therapies for use against hematological cancers? We have Yescarta, which is used against DLBCL in adults. And then we also have Kymria, which is used for relapsed and refractory B-cell precursor ALL in younger patients. Now, the amazing thing with CAR T therapy is that it has completely transformed the prognosis of these patients. With conventional therapy, the remission rate was 7%. With CAR T therapy, there are chances of having a remission of 52 to 90%, and this remains the case in 39 to 50% of these patients at 1 year. So completely has transformed the life expectancy of some patients in this group. So how do we manufacture these CAR T cells? So in this cartoon, you'll see in the top left-hand corner that the cells are taken from the body. There is leukapheresis, and then the T cells are activated, and the activation is normally done with retroviral or lentiviral vectors. The CAR T cells expand, and then the patient is given some chemotherapy to lymphodeplete them, and the CAR T cells are infused. Now, this is a cartoon by Sarju Ganantra, one of my colleagues from America, who looked at this process, but also has very nicely illustrated the side effect that occurs. So the top part is, as I've discussed, and the bottom part of the cartoon, if you look on the right-hand side, you can see one of the side effects, which is the cytokine release syndrome. And I'll come into a bit more detail about this. So as I mentioned, the lentiviruses and retroviruses are used to activate the CAR T cells, and they also may have a potential direct cardiotoxic effect. So this is the role of the viruses. So coming on to the toxicities of the CAR T cells. So in this diagram that we produced, you can see that any part of the heart can be affected by the CAR T cell in terms of toxicity. You have neurological toxicity, you have renal toxicity, hematological toxicity, general constitutional toxicities, but also you have the cardiovascular toxicities, the hypotension, arrhythmias, atrial fibrillation, left ventricular systolic dysfunction, and troponin elevation, and even cardiac arrest. And I'll focus on this. So what is the cytokine release syndrome, which is the main toxicity? This really is the body's normal hyperimmune response, and this occurs when there are large numbers of lymphocytes or myeloid cells which are activated. And in terms of the CAR T therapy, the CRS is activated because of the T cells when they recognize the CD19 cells. What happens is the hyperimmune response, and this is driven by IL-2, soluble IL-2, IL-6, and a number of different other mediators. And IL-6 is probably the most important mediator for the CAR T cell associated CRS toxicity. Now, the American Society for Transplantation and Cellular Therapy has come up with this score or gradation for cytokine release, the CRS. And what you see is there is the low grade, grade 1, going up to grade 4. And grade 1 is just a temperature with nothing else. But going towards grade 4, you're talking about patients who are intubated, who are ventilated, patients who are on inotropic therapy. They have hypotension and hypoxia. So focusing on the cardiotoxicities again, in this table, we looked at the cardiotoxicities with a number of the pivotal trials in the CAR T therapy or studies. And what you can see is that the toxicities, as discussed, range from hypotension, systolic dysfunction, arrhythmias, and also there is the treatment of these patients. And you will see in the bottom of the table that a number of these patients required treatment with tocilizumab, which acts against IL-6, and I'll come on to this. What you can also see is that a number of the patients did develop cardiac shock, and some actually died. I'll come on to this in a bit more detail in the next slides. So this table looks specifically at the cardiovascular side effects in 3 of the pivotal trials of the CAR T therapy. And you will see that in the pivotal trials, the rate of cardiac arrest and cardiac failure was low. However, you will see that in a couple of the trials, they weren't specifically looking for cardiac failure, because it was not really expected to be a side effect at that time. So retrospectively, the data may have been different. This is a very nice slide from one of my colleagues, Sebastian Smith, the president of the Polish Cardio-Oncology Society. And in this slide, you can see the cardiotoxicities of one of the pediatric groups of CAR T patients. So this is one of the earlier studies. And what you see in only a group of around 100 patients, nearly a quarter of them required inotropic support. 10% had echocardiographic abnormalities, and 6% were left with cardiac dysfunction on the completion of therapy. Now, we've already discussed the cytokine release syndrome and the grading of this, but does this have an influence on the development of cardiotoxicity? So in this study by Alvi, which was published in JACC, what they looked at was the cardiotoxicities and the relationship with CRS. And what they found was that if you had a higher grade of cytokine release syndrome, you were more likely to have a troponin release and more likely to have cardiotoxicity. So in their patients, what they found was cardiovascular events were more likely. That includes cardiovascular death, heart failure decompensation, arrhythmias, drop in ejection fraction. So these were much commoner if your grade of toxicity was high. And what they also showed in their study was that tocilizumab was really given for those patients in whom the grade of toxicity was high and they required inotropic and other invasive support. This is another study by another group in America. And what they looked at was CAR T therapy in 145 patients. And what they found was in 41 patients, there was MACE, cardiovascular death or heart failure or non-fatal ACS or stroke or arrhythmia. In their study, they found certain risk factors, which was predictive of a cardiac abnormality. These included pre-existing atrial fibrillation, being on statins, so having a background of high cholesterol, blood pressure, and diastolic function. This is a study that I was very lucky to be involved with, run by Dr. Avirup Guho from Ohio, who was heavily involved with ACOS and has been speaking in some of our earlier webinars. And in this study, what we did was identified all adverse reports associated with Kimria and Yescarta over a 2-year period from the US FDA database. And the cardiovascular events were classified into arrhythmias, heart failure, myocardial infarction. What we found was around 1,000 adverse effects were reported, of which nearly 20% were cardiovascular adverse effects. The commonest cardiovascular effect was arrhythmia, followed by heart failure and myocardial infarction. In adjusted analysis, there was an association between cardiovascular effects and neurotoxicity. And if you recall, neurotoxicity is also a common side effect of the CAR T toxicity that I showed in one of my earlier slides. The overall mortality was high at 21%, but it was even higher at 30% for those with cardiovascular side effects. So what is the pathophysiology of this CAR T-cell cardiotoxicity? Now, this is a very nice question. It's a difficult question and it's undefined. And when we kind of put this together for JACC Cardio-Oncology, we really were wondering whether this was a systemic disease or whether this was a direct cardiotoxicity. So what we know is that the pathophysiology is unclear. Some people suggest that this may be a capillary leak syndrome. It does look like the cardiomyopathy that we see in severe sepsis and stress. As mentioned, IL-6 has a prominent role, and IL-6 also has a role in myocardial depression associated with infections and inflammatory conditions. Whether this is a on-target off-tumor toxicity, with the CAR cells targeting the tumor-associated antigen in normal tissue, because we know that the CD19 is also expressed in normal B lymphocytes, and B lymphocytes do get depleted with CAR T therapy. Interestingly, in some studies, CAR T cells have also shown to cross-react with protein in normal tissues, which is similar to the target antigen. This was described in a series of 2 patients who developed cardiogenic shock and who died after receiving CAR T cells, which targeted MAGE-A3, which is an antigen expressed in melanoma and myeloma. And it was felt that there may have been a relationship with this antigen to the epitope which is found in titin, which is a cardiac striated muscle protein. So that's all about the kind of cardiotoxicities, and how to deal with them is basically the next part of the talk. And these toxicities normally develop within days and occasionally weeks after the infusion. And this normally coincides with the maximal expansion of the T cells within the patient. And high disease burden and hence high antigen load is one of the strongest risk factors for the development of this CRS toxicity and the severity of this. The dose of the CAR T infusion and the presence of other comorbidities and the early onset of CAR T toxicity are important factors. Low-grade CRS, so grade 1, grade 0, these are kind of managed in a very supportive way. If there's severe cardiotoxicity, then IL-6 blockade with tocilizumab or siltuximab can be undertaken. And if this is refractory despite tocilizumab, then you can consider steroids. And it's been found that this potentially does not affect their cancer outcome. So what is the management of the toxicity apart from the tocilizumab? So this is really the main management that we have. And what we've seen in this study is that the earlier tocilizumab is administered, the better the outcomes. And very quickly, you can see within hours, there is a beneficial effect on temperature, blood pressure, and the use of inotropes. So this is what we describe as the approach to the management of this toxicity in our center. So grade 1, supportive care. If it's grade 2 or higher, tocilizumab, and then consider the use of steroids. And this is the patient pathway that we've developed in our center. When a patient is decided that the decision is made to treat with CAR T toxicity, they are assessed in the CAR T clinic. And this is by the oncologists. They're assessed with biomarkers, ECG, and they also have a baseline echo and a baseline cardiac MRI scan. If they are at low risk, they proceed to therapy. However, if they are at high risk, then they're referred to the cardio-oncology clinic and they're assessed in that clinic. Depending upon their clinical course, if things are stable, they get their assessments repeated at 7 days and then at 3 months. However, if there is a toxicity, then clearly they will need inpatient assessment and management. So I just like to illustrate this with a case that we had in our clinic and in our CAR T service. And this was presented by my cardio-oncology fellow, Dr. Daniel Chen, at the recent European Society of Cardiology conference. So 32-year-old male, he received CAR T therapy for B-cell lymphoproliferative disorder. Patient was fit and well with no pre-existing comorbidities, and had a normal echo prior to treatment. Several days after the CAR T infusion, the patient had a grade 2 toxicity with fever, tachycardia, hypertension, and was also hypoxic. So in the initial workup, they had a repeat echocardiogram, and interestingly, the ejection fraction by 4D was normal, 56%, but the GLS was abnormal. So global longitudinal strain, which is a more sensitive marker of cardiac dysfunction, this was abnormal. CT chest did not show any abnormalities, ECG sinus tachycardia. Troponin was elevated, but only mildly elevated at 23. The NT-proBNP, however, was significantly elevated at 8,500. Patient then went on to have certain investigations and was treated with intravenous tocilizumab, and this resulted in a resolution of a lot of the symptoms. However, the patient did remain hypoxic and became short of breath on exertion and developed clinical signs of cardiac failure. So we went ahead and arranged for a cardiac MRI scan. And this cardiac MRI scan, for those of you who don't do cardiac MRI in your routine practice, It shows moderate left ventricular dysfunction, and you can see that there are some pericardial effusions, and there's also a pleural infusion. The image on the bottom right-hand side of the screen is a mapping image, which basically looks at the extracellular expansion, looks for diffuse myocardial edema, diffuse fibrosis. And in this case, there was evidence of diffuse myocardial edema and fibrosis in the acute setting. The patient was given intravenous diuretics and responded well clinically. Thereafter, the patient was started on ACE inhibition and beta blockers, and at discharge, the patient was asymptomatic. At 3 months, the patient was in New York Heart Association Class 1 and had a repeat cardiac MRI scan, which was resolution of the... Somebody else is... Thank you. And showed a resolution of the cardiac function and also the abnormalities in the mapping, the myocardial edema and the fibrosis. These values had all normalized. So the learning points were that the very elevated NT-proBNP may suggest that it's a useful marker in cardiotoxicity in these patients. And CMR can be considered as a non-invasive tool to assess myocardial injury in these patients, which of course removes the need for biopsy potentially. And the other very important point to note is the normalization of cardiac function on the MRI scan on recovery may indicate that potentially this is transient, the cardiotoxicity. So in conclusion, the CAR T therapy is really a game changer in the management of these hematological cancers. A significant proportion of these patients, unfortunately, do develop CRS. Cardiotoxicity can manifest in a number of ways, as discussed. It can lead to significant morbidity and even mortality, but potentially, if the patients recover, it may be reversible. The pathophysiology of the cardiotoxicity remains unclear. CMR and biopsy-based studies really needed for better understanding of the mechanism of this. And a number of studies are taking place in this area, so please do watch the space for more information in future. I'd like to acknowledge and thank the UCLH clinical team, the Barts Heart Center team, the UCLH research team, and special thanks to Dr. Dan Chen, the cardio-oncology fellow who is leading the CAR T study from the cardiac side. If anyone is interested in more information in general on cardio-oncology, we are hosting the British Cardiovascular Society Cardio-Oncology Day this month. So please have a search for this if you're interested in more education. Thank you very much.
Thank you so much, sir. We now request our patron to please moderate the question and answers. Sir, I'll just display the same for you, sir. Devi, sir?
Yeah, I think we will
Sure.
go ahead with asking. So, Dr. Arjun, the cytokine release syndrome, apart from the CAR T cell treatment, has also been seen to certain other molecules like blinatumomab as well as high-dose interleukin treatment. So, isn't it the same CRS and the same cardiotoxicities that is there with them?
Yeah, so I wouldn't say that it's necessarily the same. So if what I could also suggest is even in COVID-19 cardiotoxicity, there was a question as to whether this was a massive immune-mediated response, and a lot of these patients were given tocilizumab. However, the larger trials did not really show any definite beneficial effect. So I think that what we could say is with other molecules, yes, there is some kind of immune inflammatory response, but I think the difference with the CAR T toxicity is that it is very dependent on a number of specific factors related to the CAR T, such as the dose of the CAR T, whether it's given as a bolus. So I think this is a new toxicity, it's a new treatment, so we're learning more. And as I mentioned, I think further studies, especially probably biopsy-related studies, will give us more information.
Yeah. The next question is from Dr. Rajendra Kumar. So he's asking, are there some specific blood or other type of investigations which are predictive of cardiotoxicity?
Yeah, so as I mentioned in the study, in our cohort of patients, it's NT-proBNP, which seems to be the defining characteristic of cardiotoxicity. Troponin is often elevated only very mildly, but it seems that it's more cardiac stretch and pressure that is the side effect rather than a necrosis. So we recommend monitoring the NT-proBNP and the troponin if the patient develops a CRS.
Dr. Shobhadra is asking, are there any prophylactic treatment that you are suggesting for prevention of toxicity that is occurring?
Okay, thank you. So I'd like to say thanks to Dr. Shobhadra, one of my colleagues from Medical College in Kolkata, who's also on the call. And I believe that his institute is one of the ones which will be introducing the CAR T cell therapy in Kolkata, and he works in ITU. So he'll actually end up managing a lot of these patients. So it's a very great question from that point of view. Now, unfortunately, we don't really have a good understanding of the mechanism of the cardiotoxicity yet to say that this is the way to, to suppress it. It doesn't seem to necessarily be a direct cardiotoxicity affecting the cardiac myocytes. It seems more, as I mentioned, the title of the paper that we published in JACC Cardio-Oncology, whether it was more a systemic inflammatory condition which was causing a stress cardiomyopathy. So the only way to really prevent that is to prevent the inflammatory response in the first place. And that is really dealt with more by the hematologist. So trying to decrease the load of the CAR T cells. And we've seen that there is a difference between Yescarta and Kymriah in the amount of cardiotoxicity that's seen. So probably more from that side than with cardiac medications.
Okay. I think we'll skip this question next. So Dr. Purna Kurkure is asking that the most of the patients who are actually receiving CAR T treatment have received cardiotoxic drugs in the past. So how do you see the interaction between this?
Yeah, that's another very good question. And as I showed in my one of the slides, when these patients come to our center, they all have baseline cardiac MRI, they have baseline echocardiography, they also have a ECG and a questionnaire of their cardiac status. Unfortunately, as I showed in the case illustration, you can develop cardiac even with a completely normal baseline echocardiogram and even with a completely normal, no cardiac history whatsoever. So if a patient has a pre-existing cardiac disease or cardiotoxicity because of anthracyclines or other, their risk is increased. But unfortunately, even with patients with no cardiac risk, no cardiac history, they can still develop this CAR T toxicity.
Dr. Rajendra Kumar is again asking, do you need to measure blood viscosity in these patients, or is it really important to do that?
Yeah, that's an interesting question. This is something that the hematologists sometimes look at when they are looking for CRS toxicity based on their criteria, so not necessarily on a cardiac criteria. There isn't really any data to suggest that this is definitely beneficial, but I know that there are some groups which are looking at this.
I'm sure many of us would be having more questions, Dr. Arjun, but we have to move on to the next session. Many thanks to you for giving us this exhilarating talk and educating us on this rare topic. So thanks a lot. Over to you, Kashish.
Thank you so much, sir. We'll move on to our next session. Our next session is the panel discussion. Our chairperson is Dr. N.K. Warrior, Senior Medical Oncologist from Calicut. Thank you so much, sir, for joining us this evening. Our moderator is Dr. Randeep Singh, Medical Oncologist from Gurugram. And the panelists are Dr. Vamshi Krishna, Medical Oncologist from Hyderabad, Dr. Anup Khetan, Cardiologist from Kolkata, Dr. Ziba Aziz, Oncologist from Lahore, Dr. Shrenik Ostwal, Pain and Palliative Medicine Specialist from Howrah, Dr. Deepak Padmanabhan, Cardiologist from Bangalore. And I also request our chairperson to please join the panel. Over to you, Randeep, sir.
Kashish, can you see the slides, and is the audio clear?
Yes, sir. The audio and the slides are perfect, sir.
Okay, thank you. Thank you, Kashish, and it is great. And congratulations to both Dr. Vivek and Dr. Purvish. It was actually quite interesting, especially to Dr. Arjun listening. I could realize the difference. We had just started of thinking CAR T cell, and he was so enriched with the knowledge about the toxicity, and especially cardiac toxicity. Thus again saying that yes, future of monoclonal antibodies, newer therapies, cardiac and cardiologists and oncologists have to join hands finally. And when we talk about cardio oncology, we all know that in next 30 minutes we have experts both from cardiac sides as well as oncology side to discuss that supportive care drugs, how important they are in oncology. And we will be talking about very basic drugs, antiemetics, EPO, which is erythropoietin analogs, growth factors, antibiotics. So these are something which is, every day you use these drugs, but we never think of cardiotoxicity. So it is great. Dr. Vivek did tell me that when this topic was given, I was also confused. So what we will be discussing is the toxicities of these drugs. And we all know that the toxicity depends upon individual risk factors like hypertension, diabetes, dyslipidemia, obesity, age, as well as other therapies, anthracyclines, trastuzumab, and other cardiac toxicities. So to begin with, let's start. And we have Dr. Shenik also, who is from pain and palliative care. So it's a very nice, comprehensive panel. So first to Vamshi and then to Dr. Shenik. Which of these antiemetics are cardiotoxic, and do you check for toxicities in routine circumstances? And if yes, how do you check it? Vamshi and then Dr. Shenik.
Thank you, Randeep. So actually, to be very honest, I don't routinely check for cardiotoxicity in these cases, though there is literature to say that all of these have their problems, especially in terms of the QT. As a routine, a lot of patients do get an ECG and we glance at it, but specifically looking at an ECG for the QT is not something that I routinely do. Aprepitant doesn't have much toxicity, so that's something we are pretty okay with.
And among the 5-HT3 antagonist, I have mentioned only palonosetron,
Yeah.
and yes,
So,
oral, of course, NEPA, which is an oral palonosetron.
Correct. So the data says that IV ondansetron and granisetron do have cardiotoxicity. In my practice, I actually don't use IV at all. I use only oral ondansetron for almost all my patients. There I go up to 12 to 16 milligram orally, and the safe dose according to FDA is around 24 mg. So actually, I'm kind of okay on that level. But like I said, I don't routinely test for it. So far, never had any issues actually.
So what IV 5-HT3 you are using as a pre-chemotherapy
I
regimen?
don't use IV pre 5-HT3. I use oral 5-HT3. So if at all I have to use IV, I would be using ondansetron again. The dose would be around 50 again, 12 to 16 mg.
Okay, so you are not using IV 5-HT3
No, I
like
use oral.
palonosetron.
I
Okay.
use oral, yeah.
And Dr. Shenik, when you have patients among the terminal end, when you have pain and palliative cares, which antiemetic do you do you usually use in these patients?
See, the patients who are having this cardiotoxicity or the previous history of heart failure, we generally go for the ondansetron or domperidone. The other medications like metoclopramide, they generally causes the QT prolongation. So on the safer side and to prevent the further complications, we go for this antiemetics, which has the least effect on this cardiac symptoms. So yes, we do use ondansetron or domperidone.
So when you use ondansetron, you do take care of this, what Dr. Vamshi was alluding to about the dose of ondansetron. What is the maximum dose you can use? Because it was quite a long back when we got this FDA ruling where the dose was very important.
Yeah, for these patients, we maximum dose for the 24 mg per day. So it can be divided as 8 mg or it can be divided as a 4 mg.
Perfect. So you don't go more than 24 mg. Vamshi is using
Yes.
oral, and there's some data to suggest that even when you are using oral ondansetron, it is slightly cardiac safe, especially for the patients who are at risk. But yes, if you are worried about the cardiac toxicity, the simpler way is to use other 5-HT3 antagonists such as palonosetron, which is absolutely safe. Even the aprepitant, fosaprepitant is safe, and metoclopramide does cause some QTC prolongation. And I think looking at the ECG, what we used to learn in our basics, especially in the training. I mean, in our training period, it was must that every file where we used to work, all of us share common alumni, me, Vamshi, and Vivek. We will remember ECG used to be there. Thus showing that yes, ECG is important. So Anup, Dr. Anup is a cardiologist, and Dr. Anup, are you there? Dr. Anup,
Yes.
yes. So as we know that ECG, I mean, there is some relation of QTC prolongation with metoclopramide or ondansetron. What precautions as as a cardiologist you do tell to the oncologist when we prescribe antiemetics, because we prescribe antiemetics left, right, and center. Vivek and Kashish, can you help me? Dr. Anup is there, or
Sir, his mic is unmuted.
can you help him to
Anup, sir, are you able to hear me?
or Dr. Deepak, he can help us. He's also, Dr. Deepak is there. If Anup is not able to.
Absolutely, sir. I'll be happy to chime in.
Sir,
When
please.
prescribing antiemetics, I think none of these antiemetics by themselves, when used in the maximal doses, will cause sufficient QT prolongation to cause torsades. But the problem that you're going to face is your electrolyte abnormalities, which are going to potentiate these QT prolonging effects of these medications. You end up having hypokalemia in a patient who's had, say, metoclopramide. So if the metoclopramide by itself prolongs the QT by 25%, the presence of the hypokalemia itself will lead to another 25 to 50% QT prolongation, thereby giving you the potential to have a dangerous arrhythmia even with comparatively lower doses of your antiemetics. That remains one of your greatest worries. Ending with that also, when you're trying to do something like giving an antibiotic, onc patients will probably be at a more immunocompromised status than most of our other patients. So if you have an antibiotic like say ciprofloxacin and because of some vomiting you add on a drug like metoclopramide, again you're going to have a synergistic additive effect that you're going to lead to. Vagal stimulation, patients are in pain. Your patients are going to require a lot of painkillers, and sometimes even despite all those painkillers that you give, they're still going to be in pain. Pain is going to induce a vagal reaction. Vagal reaction leads to bradycardia. When you're going to have bradycardia, the potentiation of these effects of QT prolongation is again going to be there. The QT by itself is going to prolong with bradycardia. In addition to that, if you have a metoclopramide-like drug or a drug that increases the QT, you're going to be having a problem for this. The solution for this is not just not using the drug, but actually before you prescribe any drug in a cardiac milieu or in an onc milieu, you have to do a drug reconciliation. It is not possible physically or mentally for all of us to know all the interactions and the QT prolonging effects of all the drugs that we have. So it is always useful to run it through a drug checker whenever you're writing a prescription that look, are these drugs having any coexistent or a synergistic effect that is going to cause the QT to prolong. And that has to be, if you're doing an EMR based system, which is common at the places that I work at, then it has to come up automatically and the physician needs to be able to say that, look, I know the side effect is there, but I can overrule it. But a pop-up to say, come up in EMRs to say, look, there is a QT prolongation interaction. Or if the heart rate is being recorded into the EMR, look, the heart rate is low, you're giving a QT prolonging drug. These are quite important things to do. If you're going to give a QT prolonging drug for the first time, or you're going to give a drug that has the potential to prolong QT, you may want to stay off your diuretics, you may want to stay off the dose of beta blocker, even if it is a scheduled dose, because you do not know how the patient is going to interact with that drug. And if there is more than normal idiosyncratic prolongation of your QT, hello?
Yes, yes,
Sorry.
Deepak,
Yeah,
we
yeah.
are listening. Everyone is listening.
If there is
I mean,
more,
the comments are very pertinent. So there is a pin drop silence, and yes, we are all on it. Don't worry.
I'm sorry if I, so if there is a more than normal idiosyncratic prolongation of your QT, the routine dose of diuretic that may have been given there may actually potentiate that because of electrolyte abnormalities. The routine dose of the beta blocker that you are giving at that point of time may actually slow the heart rate more, which then can become arrhythmogenic. Remember, QT prolongation by itself or arrhythmias by itself are also a big function of the milieu that you are in. If you are in a milieu where there is a lot of inflammation, if you are in a milieu where there is a lot of electrolyte disturbance, arrhythmias are going to come. We are
Thank you.
more
So
worried
I
about
will,
ventricular arrhythmias, but atrial arrhythmias can also happen. Thank
so
you.
I will interrupt you here in the interest of time. But yes, thanks a lot. All the comments were actually very pertinent to the discussion. And what is the carry home message is that apart from dyselectrolytemia, you shall have a check on drug interaction. And in my previous, that reminds me of the previous institute EMR, where after 7 days of admission, we used to get a pop-up that you have to start the patient on, I mean, low molecular heparin, so that the patient doesn't go into thrombosis and clots or something like that, where you have drug interaction happening. So thanks for the comments. We'll proceed further, and you have actually covered a couple of things which were related to QTC, even related to antibiotics. So thanks for covering 2-3 slides together in the discussion. So I think we will come back to our oncologist, and we do use two people who use maximum this ESA, which is erythropoietin analogs. Our first nephrologist, which we don't have in this gathering, and the second are oncologist. Among the oncology, we use ESA for the patients who have anemia, especially in the range of 8 to 10 gram per deciliter. We also use in patients of myelodysplastic syndrome, and mainly EPOs or erythropoietic stimulating agents are used in metastatic malignancies, non-curative solid tumors. So this is the setting, just to have, just to apprise the cardiologist in the group. Now, Dr. Warrior, thanks for pitching in. Dr. Vijay Patil could not join. And so does ESA increase the risk of thromboembolism?
Yeah, definitely. The erythropoietin stimulating agents, if you are using a higher dose, they can definitely produce thromboembolism. And remember that way back in 2007, FDA has banned the use of erythropoietin in higher doses in solid tumors where the solid tumors are not curable. So definitely this produces a higher chance of thromboembolism. Whether have you ever seen such event in your clinical practice? I've not come across it, but we are not picking up that many. That may be the reason.
So the risk is actually high. Sorry, there was some disturbance. So the risk is very high. And if you see the 2012, when 2009 and 10, Dr. Warrior was saying that there was a warning from FDA similar. Just 2 to 3 years after that, there is a Cochrane review which is saying that the relative risk is at least 1.52. And if you see among this, the confidence interval is 1.34 to 1.74. So thus there is 25 to 30% or even more increased risk of thrombosis when you are using ESA. And the clue, where Dr. Warrior has very rightly said, the clue is the dosage. And the much more important clue is that you maintain your hemoglobin in a range where the chances of thrombosis are very less. Dr. Zeba, your comments upon the dosing guidelines, which are already there on the slide, and what precautions you will take when you use ESA so as to avoid thrombosis.
Randeep, we generally don't use ESA unless it's absolutely necessary, and we use it up to the hemoglobin of 10 or 11, not more than that. Once the hemoglobin goes above 11, we stop it. We generally use about 10,000 units sub-Q weekly or twice a week. Hardly. We put on anti-embolic stockings. We make sure that the patient is active. We generally prefer not to use it in the bedridden patient and we transfuse packed red cells. For me, since the guidelines have come out, and even before that, we noticed that for patients who were bedridden or with a performance status of 4, they were the ones generally who had increased risk of DVT. But at 11, absolutely no. Whether it is supportive care or part of therapy or whatever. So hemoglobin increase up till 10 to 11. That's it. Stockings, activity, and regular walking, exercises. This is what we do. But we hardly use it here.
And actually, I agree with your point that if someone is on prophylactic doses of anticoagulants, that is also that patient is actually
Yes.
no for eptoin alpha or darbepoetin alpha, because even in the guidelines, if you go in detail, there have been a couple of guidelines in 2017-18 where the FDA has supported and has overruled its previous what Dr. Warrior was talking about. FDA has issued a 2017 REMS guidelines, which is risk mitigation strategy guidelines, where they have said that it is safe to use ESA in metastatic settings. But yes, the key is that please keep your hemoglobin less than 12. And very
That's it.
rightly just said that the patients who are mobile and others,
Yeah.
But if you think, sorry, I will just, but if you think that if you use LMW heparin and then put them on darbepoetin alpha, that is absolutely wrong what Dr. Zeba wanted to say. Ma'am, your comments.
Yeah, that's absolutely true.
Any
What is the point of doing both of the things and you're mitigating it?
Exactly, fine. And yes, in the patients such as those who are on steroids and on lenalidomide with steroids in myelomas and others, they have not to be kept on it. I think Dr. Deepak was anticipating about this question and he has already touched. Dr. Deepak, a very brief comment. You have already touched upon it. Anything you would like to add on this slide about the usage of antibiotics? And I mean, you have already mentioned about the fluoroquinolones as well as macrolides. Just a very brief comment, couple of 30-40 seconds about antibiotics and cardiotoxicity.
I think we don't give antibiotics long enough for the individual antibiotics to cause direct cardiotoxicity. But the arrhythmogenic potentials of antibiotics in concert with other medications is a critical one. We should always be on the lookout for that. And coexisting systemic issues with antibiotics, that again can precipitate electrolyte imbalances. Say it causes kidney issues, it causes bleeding issues. Those again can cause
I will interrupt you.
abnormalities.
Does the QTC prolongation happen if you're using a long antibiotic? Because generally, I mean, these antibiotics such as fluoroquinolones and others, I mean, do you expect that when we are using them for more than 5 days, 7 days, then only the QTC prolongation will happen?
No. I don't think that is the mechanism for the QTC prolongation. It's more of a class effect. It happens when it happens directly. It doesn't have a cumulative dose-related effect as far as I know. We've never had that, but for sure we've seen synergistic effects. And I come back to the same point. You have to reconciliate your drugs when you're looking at prescribing them, because the additive effects is what causes a problem. As an electrophysiologist, we've used a lot of QTC prolonging drugs, but so long as you don't add on a second drug, which again potentiates the effect of drug number one, you don't get into trouble. It's very rare that you get into trouble by a single drug by itself in the absence of electrolyte abnormalities.
Deepak, I will ask you, and do pardon me my ignorance being an oncologist. I mean, suppose I have a QTC of 0.43 millisecond, and when will you call it a prolongation? I mean, 0.45, 0.55, or 0.50? And can you guide us? Because we have, and sometimes we see that when we do the ECGs, and sometimes there is a lead placement problem, and then I tell the patient that just you get a good ECG from my hospital or from my nurse in front of me, and then the QTC is comes to be normal, or we just tell the patient to come day after. I mean, these all small practical things. Can you just give another, being a electrophysiologist, that what is prolongation and what steps we shall take before we tell that yes, it's a prolongation? I mean, you got my concern.
Yeah, absolutely. A couple of 2-3 important things you touched about, sir. Number one, where do you measure QT? You have 12 leads with 12 QT. So, kaun sa QT measure kare? So, the preferred one is where you can see the QT the best, lead 2, lead V5. These are your sites for measuring the QT most of the times. You want to measure the QT to the tangent. You do not want to take the end of the T wave. That is not where the QT is measured. It is measured to the tangent to the horizontal. So sometimes you may end up having a longer QT if you measure to the end of the T wave. You've got to figure out whether there is a U wave or not. Again, U wave is critical because U wave is seen in the precordial leads. Just after the T wave, sometimes people have mistaken it for the P wave. So, chota sa ek small little U wave is present in the precordial leads at around leads V4, V5. You exclude the U wave unless the patient has a prolonged QT. If the patient has a prolonged QT, values of which I'll just come to in a minute, then you have to include the U wave in the measurement of your QT. Now, what are the values? Routinely, you want to say 0.44 for males and 0.46 for females is normal QT values. Anything that increases the value of your pre-existing QT by more than 25% or an absolute value of more than 500 of your QTC is what is prolonged QT for that particular drug for that particular patient. Rule of thumb, if you don't understand all of this, if the QT is more than half the RR is say X amount, or QT, the QT extends to more than half the RR, you are having QT prolongation.
Okay, Deepak. Thank you for these points. I will proceed further, and points very well taken. Measure in lead 2, measure where you can see properly. Don't go till the end of T. And yes, you have already said 25% increase or more than RR interval. Just to reiterate, and thanks a lot. I think these points were really helpful. I had some bandwidth problem, so sorry to switch on, switch off my video because I was not able to hear properly. I will just switch it on if my connection is stable. So just bear for the time being. I think I will just skip this clinical history of hypokalemia, medications. Dr. Deepak has already said, take care of drugs like amiodarone, use less arrhythmogenic antibiotics where possible. And he has already mentioned actually this point, automated alerts. If you have electronic prescribing system in your hospital, please tell your IT to put automated alerts wherever possible. So these points were already covered. So Vamshi, coming to CV, I think, and Kashish, just let me know the time, please. Kashish, just let me know my
Sir,
time.
9 minutes left, sir.
9 minutes. Okay. And just let me know 3 minutes before. Okay. Vamshi and then Dr. Anup. So CVC related complication, very brief. Vamshi, one of your dreaded complications you can remember, I mean, where your heart was getting arrhythmias. Some one or two, because then we proceed further.
So the biggest problem, if I had anecdotally, I have to say, was when we were inserting a femoral and the catheter broke and it migrated up till almost the heart. So we had to panic call the
I also have
cardiologist.
one such.
Yes, so we had to panic call the cardiologist.
I also have one such arrhythmogenic.
Yeah, they were able to pull it out. So that went luckily well for me. But otherwise, all these complications you have noted do happen. Arrhythmias, honestly speaking, I am not seeing much because all my ports and all my CVCs are placed in the OT by the anesthetist and the surgeon. So they have a full team to manage it. And we usually do not have much complications there. Occlusion and thrombosis, yes, we are seeing. Again, not that commonly, but it is one thing which we need to watch out for. Air embolism, so far not yet seen. Biggest challenge, of course, is the complication of infection and, of course, local site wound infections. Those are the things which I see more often, actually.
Okay, fine. Dr. Anup, about your experience, about all these, have you faced ever? You have been approached by your oncology team about the catheter going into the ventricle, and you have to do an angio and take that broken tip out. It has happened with me also once. And do we have Anup now, Dr. Anup online now? Is his, the IT issue sorted out, Kashish?
Anup, sir, are you able to hear us? Sir, if you can hear us, can you connect with your phone?
I am not able to see, and we can then proceed further in that situation. We will just wait for a second. Dr. Anup? Okay, so I will proceed further. Thank you, Vamshi, for enumerating the side effects. I have also seen arrhythmia once during a PICC line insertion, which we do. Of course, if you talk to the surgeons, they do notice intermittent arrhythmias in the, but they are doing the insertion of the port under the C arm, and so they can note the position and other things. So coming to what Vamshi was telling, and Dr. Zeba and then Dr. Warrior, we all have faced catheter thrombosis. How do you manage in your practice? We can have Dr. Zeba and then Dr. Warrior. Dr. Zeba?
Yes. Catheter thrombosis is not that common with us, but we do see them on and off. And what we do is we put them on heparin initially, and then put them on low molecular weight. But again, basically, these are the patients where we are talking about leukemic patients, patients who are sick, and there is a problem because you need to insert another catheter after that. For our long-term leukemia patients who we are giving inpatient chemotherapy. However, we do give heparin and then follow it by low molecular weight heparin. That is the way we manage it.
Have you started using DUAX? I mean, direct oral anticoagulants.
Yes. But you know, we are using it, but it's a very tricky situation because at the same time, especially for the leukemia patients, that's where most of our catheters are, and there is where most of the thrombosis occurs. It is not in the solid tumors where we can take it out. We are comfortable with using DUAX and everything else. But it's in these patients where there's a major problem with antibiotic, with sepsis, with this, and you're damned if you do and you're damned if you don't.
Dr. Warrior, a very specific question to you. Have you salvaged a non-infective thrombosed catheter? Especially in a patient like leukemic, Dr. Zeba is saying, where it is your lifeline. I mean, a high
definitely. We rarely remove the catheter, and a couple of occasions we could salvage the catheter, especially when it is the lifeline, as you said. And the only one indication for removing, as according to me, is the any threat to the limb. Otherwise, or even the superior vena cava obstruction, or any symptoms of superior vena cava obstruction. Otherwise, it's fine. It is we generally manage with low molecular weight heparin.
Perfect. So very important message that you can salvage your catheter. And he has said very rightly that if you are not having a threat to the limb or SPC obstruction, and second, it shall not be infection shall not be the cause of thrombosis. And absolutely, even in the guidelines, there is a support to do this, that if you are not having a lot of problem, you can salvage the catheter, which I've also tried once or twice. Dr. Warrior, in continuation to this, as you are of the school of thought to salvage, have you done catheter directed thrombolysis?
Yeah, we had done with urokinase, and one occasion we had even the chance of using TPA. So that, because that was very crucial, and we had to get it back, and luckily we could salvage the line. But that is only for once. The urokinase we very often we use, and the results are much better. And I feel that whenever there are no infection or no signs of infection, we have to use the ways like the urokinase or the low molecular weight heparin, so that we can get the patency back.
Randeep sir, 3 minutes left, sir.
Okay, okay, fine. So only contraindications, as Dr. Warrior has mentioned, I have tried twice and I have been using TPA. I have not used urokinase because because of the dilution, I had a problem, because the strength of urokinase vial, which is available, I don't know the specifics. There the problem happens because you have to put a very low dose when you do a catheter directed thrombolysis, and the volume is just 1.5 to 2 ml, depending upon what catheter you are using. I mean, whether it is a port or whether it's a PICC line, and the indications are contraindications are there on the slide. DUAX, it is direct oral anticoagulants, and we have a couple of them, especially rivaroxaban and apixaban. Rivaroxaban is the one which has the maximum experience, and there is phase 3 randomized trials, not one, at least 2 to 3, where as compared to low molecular weight heparin, dalteparin on the slide, there have been an equal results with compared to, I mean, there are rather better results. If you see recurrent VT 7.9 versus 11.3, edoxaban versus dalteparin, edoxaban is not available here. Rivaroxaban 4% versus 11%, apixaban is 3.4. So Dr. Anup is not there. Dr. Vamshi, use of DUAC for cancer thrombosis. I mean, whether it is any sort of, we are not talking about the line thrombosis.
So actually, interestingly, Randeep, I have been using dabigatran quite a bit. Eliquis, not so much. But actually, if you look at the data seems to be stronger for Eliquis and other things. In fact, dabigatran is not really very much approved. The trial did have around 6 patients, or 6% of cancer patients. So practically speaking, dabigatran is what I'm using. But I think Eliquis is something I need to shift to. And it is something we are using.
Did you have any major bleeding problems?
So far, not yet
Any major
encountered, but again, I guess we have to be careful. We need to see what are the problems. So if you have a large ulcerating mass somewhere, probably that's an indication where you might not want to use it. Bad cervix vagina with a fistula somewhere where you probably want to avoid it. You know, stuff like that. But so far, not major bleeding problems.
Drug-drug interactions?
Again, so far, not much seen.
So the drug interactions are less, but the only place, just to add to you in the interest of time also, Dr. Vamshi, I have been using DUAX almost now 2 years. I'm very comfortable. I had a lot of reservations. I started using maybe around 2017 when the guidelines were not out. But I'm now very comfortable. And the main reason was about the patient not able to take LMW heparin subcutaneous and the worry. Now, only 3-4 places where I found after preparing this slide, someone who has a GI ulcer, someone who has a GI or GU bleed, whether it is due to gastritis or a tumor, as you pointed out, a tumor in the genitourinary tract, a gastric ulcer, a peptic ulcer, or has a diffuse gastritis, or has a platelet less than 50,000. Those are the patients where you will prefer LMW heparin over DUAX. But otherwise, if you see as per the literature and the increasing experience of oncology community and the support of cardiologists. Even the cardiologists, whenever I have been interacting in the last 1 year, they have been very open that yes, please use DUAX. There is no problem. There is enough data to use it. These are the precautions which you have to take. I think we come to the last slide. This is the last slide, and Dr. Shrenik, you can help us. And this question is, to my mind, I am also not very clear. Does opioid analgesics relate to cardiotoxicity? I could not find much literature. I could find some. These are just screenshots of.
Yeah, so only the low dose opioids are absolutely safe in patients who are having the cardiotoxicity. You can say a tramadol or a tapentadol might be cardiotoxic to a person due to its anticholinergic effect, but as compared to the morphine and other fentanyl or buprenorphine or even this methadone, these are absolutely safe when a person who is having cardiotoxicity or the cardiac failure. So as per the pain severity, we can go for use of low dose of morphine to to a higher dose of morphine or the fentanyl. So yes, we can use opioids, and these are relatively cardio safe as compared to the toxicity effect.
What dose of morphine to your mind? I mean, because when we use morphine, we go up to 80, 100 mg per day easily. I mean, in oncology, and same as your usage. So does at dose of 60, 80 or 100 in a patient who has predisposed cardiac comorbidity can lead to some arrhythmias or other cardiotoxicity?
In my practice, I haven't seen any patient who has been on a morphine and it has developed some sort of cardiotoxicity, or the patient who is already having the cardiotoxicity. Because low dose of starting with a low dose of opioids, which we use for this heart failure patients for breathlessness specifically and pain. These are absolutely helpful for these patients. While the patients who are having severe pain, we can go up to 200 or more than that of morphine as compared to their pain severity.
Okay. Thank you, Shrenik. And if we have 1 or 2 minutes, and with the permission, Dr. Vivek, do you want any point to be from the chat box? I could not see the chat box. I was full screen.
Yeah, I think Kashish, if there are any questions.
We have 1 or 2 minutes, Kashish.
So we got the questions, so we can take those, sir.
This I have to do, or
so I'll request our chairperson, Dr.
Okay,
N.K.
fine.
Warrior,
Thank
to
you.
please moderate the question.
Thank you, Kashish.
Thank you so much,
Thank you,
Randeep,
Dr.
sir.
Vivek. It was actually, I really enjoyed preparing this. This was a very different topic, Vivek, but I really enjoyed preparing the slides, because every slide was prepared new, because we never touch upon these things. And actually, it was very great to have cardiology friends to help us, especially a very simple point, how to measure QTC and what is, these things also sometimes we get confused. Thanks a lot and congratulations to the organizer. Thank you.
Yeah, thank you, Dr. Randeep, for an excellent discussion. Actually, we are all new to this area of cardiotoxicity, though we have learned so many side effects of commonly used drugs, but it's very often overlooked, and especially in the setting up supportive care in oncology, and everything will be attributed towards the progression of disease. So this is eye-opener. And I will just read some of the questions, and then we will, I think from most of the questions have been already answered, and 1 or 2 points I just want to repeat as a take-home message. As Dr. Deepak rightly pointed out, the underlying electrolyte imbalance is very often the reason for the prolonged QT prolongation, and resulting in toxicity point syndrome. The disease, the drugs per se, or when you are using a single drug, probably the problem is not that high. But when you are combining 2 drugs which can prolong QT interval, might end up in the QT prolongation if there is a electrolyte imbalance as well. So that is one thing. And second thing about the erythropoietin, which Randeep has already mentioned, and after the initial ban lifted in 2017, if you keep your hemoglobin level at 12, probably erythropoietin is safe to use in the clinical situations, especially in the metastatic solid tumors as well. The third point is about the catheter and catheter-related infection, and the way we are all doing, or we are trying to preserve the catheter. we can, if you try you can definitely keep the catheter if there are no infection. And nowadays the direct oral anticoagulants is one of the choices, and we have, and it is, the studies have shown equal results with low molecular weight heparin in the particular setting. So with this, I think are there any questions to be discussed in that? I think
So
all
the
most of,
questions are on the slide, sir.
yeah, yeah, I think.
So you can read the slides, sir. Though I've shared the screen, sir.
Oh yeah, you have okay. Yeah, from Dr. Vivek, that is in bone marrow transplant patients, we commonly have patients in long course of antimicrobials. Any cardiac toxicity that we should expect or look for? The panel members or Dr. Randeep
So the
or Dr. Deepak is there. I think Deepak has already mentioned about, but in our setting, especially for the bone marrow transplant, some of the prophylactic antibacterial, especially the quinolones, which we have already mentioned.
I think in
Anybody?
our practice, what we use, I mean, the worrisome is only about quinolones. We are not using macrolides too much in oncology. I think it is very, very less. It was only COVID where we have started prescribing azithromycin, but pre-COVID, I think the usage was occasionally especially in the febrile neutropenia. But yes, we use lot of fluoroquinolones in the prophylactic as well as OPD management of febrile neutropenia. And there, at least a check on the electrolytes as well as the drug interactions is the key, as Dr. Deepak mentioned.
The second question is from Dr. Vamsi Krishna. He asked whether how accurate are the automated reports to corrected QT interval from the reports. And Deepak has rightly mentioned that, rightly answered that question, that it is not at all accurate. So we need to calculate separately. So the third question, yeah, again from Dr. Vivek, what is the dose of dabigatran? It is 150 or 110? Anybody? Dr. Deepak? Deepak, are you hearing?
So, Dr. Warrior, the dose is 150 mg BD, but in some patients, why 110? Vivek has mentioned in some patients who are elderly, have a borderline creatinine clearance, borderline platelets of 75,000, or has some episode of, I mean, a GI or something where you feel we do go to 110 mg BD. But generally, the dose is 150, but you can easily make it 110 if you are suspecting a drug interaction, as well as elderly and others like our patients are.
Okay, I think that is the end of the question. And if there are no more questions, I will wind up the session and over to Kashif. Thank you so much for the patient listening.
Thank you so much, Warrior sir. Thank you so much, Randeep sir, for the wonderful session. And thank you to all the panelists. We'll move on to our case presentation. Our chairperson for the session is Dr. Naveen Khatri, medical oncologist from Mumbai. Thank you so much, sir, for agreeing to chair the session. We request you to please introduce our case presenter. Over to you, sir.
Thank you, Kashish. Good evening, everyone. Firstly, I would like to congratulate Vivek for an excellent meeting. It was certainly an eye-opener for me, and I really enjoyed the last 1 hour. So we come to the case presentations. We have two speakers. The first one is Prashant Mehta, and the second one is Dr. Rahul Bhargav. So Dr. Prashant Mehta is a medical oncologist at the Asian Institute of Medical Science, Faridabad. Over to you, Prashant. Prashant, are you there? Kashish, can you please?
Yeah, Prashant sir, you'll have to unmute your mic. Oh, sorry, sir, you'll have to unmute your mic again. Yeah.
Yeah, can you hear me now?
Yes, sir, I can hear you, sir.
Okay, good.
Yes, Prashant.
So you can see my slide.
Yes, sir, we can see your slides.
So I'm discussing this post-HSCT cardiac dysfunction 1 patient. So this patient is a 18-year-old boy, was a very severe aplastic anemia post-IST failure, L-thrombopag refractory, and he had history of multiple blood transfusions. His organ function was normal. There was no matching donor. The DSA was also positive, 10,000 MFI, a very difficult situation actually. Patient was severely neutropenic and was infected also. But we managed to desensitize him with our, plasmapheresis rituximab by VIG protocol, and we took him up for a haploidentical HSCT. And we utilized this protocol with Rabbit ATG, Flucy, TBI2 Gray, PTCY, CSA, MMF. And this was a CD34 dose CMV. We routinely monitored day plus 5 onwards. He developed sepsis, ill pneumonia, all, in this situation, many usual complications which you can have actually, and pneumonia, ARDS, gram-negative sepsis. And the LVEF was 60% till that time. He was treated with HFNC support, and day 16 he engrafted. We thought he has recovered, but day plus 21 he had a secondary drop in blood counts and spiking fever. And we detected CMV viremia, 50,000 copies per ml, worsening hypoxia infiltrates, again put him on HFNC. We found that the cardiac biomarkers were raised this time, and he had LV ejection fraction of 25% only. He also had seizures, altered sensorium, and progressively was worsening. MRI had some T2 white matter changes. CSF was neutrophilic leukocytosis as well as raised proteins. And we do a multiplex PCR in the CSF with known as SES, and it showed up CMV positivity. So thereafter we started on Jancyclovir and diuretics. We took help of our cardiology team as well, and they managed the low ejection fraction, and whatever component of respiratory dysfunction was because of the cardiac problem, they managed it. And we made a diagnosis of CMV meningoencephalitis as well as myocarditis possible. And he started improving after Jancyclovir, and the fever also responded to steroids later, but the fever was not responding initially, and we had to use some low dose steroids. There was probably some ongoing immune mediated fever, and he recovered by day 40, and the counts also normalized. CMA became negative. LVEF was also improved, but he did recover, and we were very happy about this patient. But at 3 months or so at home, he died of COVID-19. So that was the bad part of the whole presentation. But thank you. We can have such complications in HSCT, and this one we were able to manage, though the final outcome was not in our favor. But thank you.
Thank you, Prashant. I think we will go ahead with the other case presentation and then have our experts and then Q&A. So request Dr. Rahul Bhargav. He's a hematologist at the Fortis Hospital, Gurgaon. He will present the next case. Rahul?
Thank you, Dr. Naveen, and thanks, Vivek, for inviting us. And Dr. Purvish, Parikh, it's a wonderful concept, Vivek. I thoroughly enjoyed sitting here and listening to all the common mistakes which we do during our haplotransplants about MSET and so on and so forth. So again, haplotransplants, as we getting embarked upon more and more haplotransplants. 44-year African origin, treated with UKLL 5 months. Daunorubicin dose was heavily given. The cumulative dose was 120 probably to 150 milligram per meter square. Brother was the donor, same blood group. Conditioning was flus, bu, TBI, 2 grays, and day 3 and 4 of PT-Cy, 50 milligram for 2 days. Dose was 6 million. Prophylaxis was levoflox and posaconazole. Why I'm talking about posaconazole is there are interactions which leads to the prolongation. Uneventful infusion on day 16, 1 day after engraftment, developed breathlessness. Echo showed ejection fraction of 25%. Fever absent, but antibiotics, Miro and Targo were tapering. Trop-I was negative. Managed conservatively at 6 months. Still, the ejection fraction was still 35%. Angio was not done. Patient tends to go and relapse 1 year down the line, which was like in the month of April back home in Nigeria. So the most important thing was the previous history of anthracyclines, the dose of cyclophosphamide, and there was a drug interactions which were associated leading to real myocarditis, carditis leading to the ejection fraction being low. And we know this high dose cyclophosphamide can cause a problem, and PT-Cy, we are finding it up to 9% patients developing some kind of a cardiac problem. So we need to be very, very careful, and that's why we have changed our prophylaxis from posaconazole and azoles to echinocandins. So these are the few things which are there: pre-transplant, abnormal ST waves, hyperemia, and recalculated dose of cyclophosphamide, which needs to be seen as a risk factors. And this we are seeing too often, we are seeing the cardiac dysfunctioning happening at some point or the other. People tend to have a low ejection fraction, but they tend to return. So I would say, please be careful about the drug interaction as been highlighted in the previous talks. Thank you.
Thanks, Rahul. Now we have two experts, one from the oncology division and the other from cardiology. Um, I think we will first request the cardiologist. Is Dr. Sumit Sethi there? He is a cardiologist at the Max Hospital, Delhi. Dr.
Yes.
Sethi, are you there?
Yeah, I'm there.
Yes.
And very interesting discussions. I must say, I feel like the odd man out in the medical oncology circles. Majority of the things are like bouncers to me and passing all over my head. But, I would actually be happy to answer any questions. I mean, I don't think I'm the right person to be contributing, by way of any active intervention to you all. But yes, as a cardiologist, I mean, I don't really specialize in cardio oncology, but my friends here who are oncologists do get back to me from time to time. And the problem is that we are involved when the patient is already, having far advanced drop in ejection fraction or is having arrhythmias. Is the time when we actually, get into the system and look after that patient. Unfortunately, we are not in any way involved with the pre-transplant workup or the time when the patients are being put into onto chemotherapy, etc., so that we have an idea as to what a pre therapy workup can be done for these patients, so that we can pick up those vulnerable patients who may have a tendency to develop severe LV dysfunction post chemo or post transplant, etc. And I would say that someone who's got a basic history of, say, hypertension, dyslipidemia, diabetes, or maybe has had can you hear me?
Yes, we can hear
Or
you.
maybe maybe someone who has been treated for his oncology disorders with, say, a high dose of anthracycline in the past, is someone which we would recommend to get a pre therapy ECG and echo done, so that at least we can pick up those cases where there may be mild LV dysfunction, and we can kind of advise our oncology colleagues to be a little more careful. uh, that's my submission, but I'll be happy to answer any questions that would be coming my way.
Thank you, Dr. Sethi. I think one of the most important things for the oncologist is that how do you really predict that which patient will develop cardiac dysfunction? Like both the patients, they had normal echocardiography before transplant, which we routinely do. And I'm not sure whether any of the biomarkers are sensitive enough to predict that this patient may develop. We use some cardiotoxic drugs
Yes.
in our conditioning for transplant. But what what we face most of the time is, suddenly we're taken surprised, by someone whose cardiac dysfunction develops, and it's always multifactorial. There is sepsis, there are other issues with the patient. So in would you be, I mean, would you know which biomarker, if at all there is, which will help? It may be good for the oncologist to understand if there is any biomarker.
So actually, for someone who has a normal echo ejection fraction or normal diastolic and systolic function and a normal looking ECG, it's very difficult to predict if that patient is going to. There is no biomarker as such which we can say that, if you have a raised biomarker, that particular one, this patient is likely to have a cardiac dysfunction later on in the course of his therapy. It's only when they become symptomatic with, say, a breathlessness or features of congestive heart failure that we really resort to, very commonly NT-proBNP to really make out whether, how severe or bad is the LV dysfunction. The level of NT-proBNP actually correlates very well with the severity of the disease process that the patient may be having. But other than that, if it's an elderly with the risk factors, we would rather, recommend that besides an ECG and echocardiogram, it would be important to rule out maybe some underlying ischemia in that kind of a patient, and advise them to undergo a stress thallium, a stress echocardiography, or at least a treadmill test to pick up any underlying ischemic heart disease, which may actually bring about severe LV dysfunction in the course of therapy. But maybe for a youngster, I think the first case was a very young boy. It's so difficult to predict. I mean, he's unlikely to have any ischemic heart disease. If his pre-therapy echo and ECG are fine, then I think it's just a cardiotoxicity of the drugs being used, the oncology drugs being used, and you just got to manage these patients once they become symptomatic and have drop in LV function. As I was going through, some literature, there has been a study, called the Overcome trial, in which they have used ACE inhibitors, and allopurinol and a beta blocker called carvedilol in malignant hemoglobinopathies in patients to see whether it was protective. And it was at 6 months by echo and by MRI, they could find that the preservation of ejection fraction was better in the patients who were on ACE inhibitors and beta blockers. But then these are the kind of drugs which cannot be given to a patient who has normal LV function to start off with. But maybe if someone has, say, an ejection fraction of 45 to 50%, what we call mid-range reduction in ejection fraction, such a patient, if they can be put pre-therapy on ACE inhibitor or beta blocker without any contraindication, then maybe, we may be able to, preserve their ejection fraction later on in the course of their disease.
So one of the questions which we have right now in the chat box is from Vivek, that, is there any role of the GLS in predicting cardiotoxicity? And one of my questions is that between the systolic function and the diastolic function, which is probably more important in cardiotoxicity?
So I think I'll take your second question first. It's definitely the systolic function which is more important. Reduction in systolic function is directly contributing to symptoms of congestive heart failure, as well as to the onset of malignant atrial or ventricular arrhythmias. Preserved ejection fraction or diastolic dysfunction is something which may lead to symptoms of congestive heart failure, but we do not expect it to have a very malignant course for the patient. And I think Dr. Vivek Agarwal's point about GLS is very, very apt, because global longitudinal strain is a marker which actually picks up cardiac dysfunction even before the drop in ejection fraction. So I guess, if a patient has had past history of being treated for his disorder, and even if he's getting a normal ejection fraction on echo, if the GLS is abnormal, then that can be a pointer that, yes, maybe this patient has to be very, very carefully watched. He may develop severe LV dysfunction, arrhythmias down the course of his therapy.
So, one question would be, should we always ask for the GLS in our patients, especially those who undergo transplant, because, there are too many risk factors for cardiac dysfunction?
I would absolutely agree with that. In fact, if major oncology centers are in big hospitals, in tertiary care hospitals, where the echo services which are being provided do give GLS as a routine marker in their echo reports. It's not something that one has to ask for, but yes, if your center is not doing it routinely, then it's very important for the oncologist to ask for GLS in the echo as well.
Thank you, Dr. Sethi. It was very enlightening with your points which you have discussed with us.
Thank you so much.
We certainly need inputs from so many other specialties in medical oncology and transplant that, I always feel that you need to be a very good internist if you're doing transplantation. Now we switch to Sharad. Sharad, are you there? Sharad Damodar is a hematologist at the Majumdar Shaw Cancer Center, Bengaluru. Sharad, your viewpoint on the two cases and expert comments from you.
Yeah, thank you, and thank you, Vivek. Kashish, if you can just present the little slide which I made a few pointers there.
Sure.
Yeah, so the focus there was on cardiotoxicity of BMT conditioning, and just looking at the two cases, you had one young person there, the 18-year-old, and the other one was slightly older. So there are factors which we need to consider, and clearly they have been delineated in transplant patients and in patients who had chemotherapy. As age, it kind of goes up as you age. Secondly, if you have comorbidities, again, that's a risk factor. Mediastinal radiation specifically. Iron overload, which we see in our thalassaemic patients, that's another contributing factor for development of cardiac toxicity post-transplant. Cumulative dose of anthracycline. This is something in somebody who's had a lot of chemotherapy, it invariably comes back to bite you during transplant. And clearly the anthracycline is a big factor for cardiotoxicity. Cutoffs of 400 mg per meter squared or sometimes even up to 450 mg per meter squared have been used. And cyclophosphamide, dose and conditioning. This is again a very important thing. Earlier, when we used to use the BUSI protocols, we had a significantly high dose of cyclophosphamide. That gradually moved to the flu-BU conditionings. But lately, with the haplotransplants picking up, like you saw in the previous case, that also is beginning to become a factor which has to be now looked at. This is coming not in the conditioning, but this is the post-transplant cyclophosphamide. And clearly, the number of haplotransplants is really jumping up in our country. And even though most of us don't factor this in, I think it's an important thing to consider at the doses at which we are using. So in those two cases which were presented, I think the first one looked like, the viral infection because of the CMV myocarditis. This is something which we have to remember in our patients. We do monitor CMV and sometimes they can present like this. And like Naveen mentioned, we always have multifactorial issues when somebody drops pressure and then you do an echo and find the EFS drop. It could be just sepsis, it could be the drugs you've used in conditioning, it could be a viral infection. So all of these tend to come together. And it's very difficult to kind of hair split and clearly implicate one of them, but you certainly need to be aware. And from a practical perspective, I think, from whatever discussion we've had from the time so far, the role of monitoring with multiple ECGs, I think, is something which we should do, and I think do more of it. I think we are doing to a reasonably good extent, and trying to get people to come into the BMT unit and do echo. A reliably senior person or somebody with a lot of experience to come and do the echo and tell us about those changes. I think this is a practical problem. Sometimes you may just get a junior technician coming in because not many people are willing to come into the BMT unit. So this is something which we face, and I think we should also be asking for more frequent echocardiograms. The next slide, please. So when I try to look up, when we look at all the drugs which we use in conditioning and transplant, every single thing is actually mentioned as some potential cardiac side effect, either in the literature insert itself or whatever has been discovered in the post-marketing surveillance. So you get this little footnote saying that this has been described, this has been described. So every drug has got some mention of arrhythmia, heart failure, plus minus a cardiomyopathy. A drug like etoposide, typically even when you're infusing it, you can get hypertension. So these are all known issues which we have. So it's really difficult to say that, a particular drug will not produce any problem when you're using it in transplant. We just need to be aware. Even though it is rare, you might have to factor that in. Next slide. So I just went through and pulled out, some literature over the past 10, 20 years. And this was one which was published way back from the University of Minnesota from Weisdorf and his team. Complications in over a 20-year period. Next slide. And surprisingly, the number was quite low. So the point I'm trying to highlight here is the numbers are very, very variable, from about 1 to 2% to as high as 10 to 15% have been described in various studies. So in this particular analysis, it was, only about 26 patients who went on to develop this problem. There were 13 deaths, and they implicated primarily the role of cyclophosphamide and radiation. So when you use TBI, you should really remember that they tend to, shield the lung, but the heart is not shielded. So there will be exposure there. And similarly, when you're doing mediastinal artery, they try to protect it as much as possible, but there can be some involvement. So this is something which we need to remember when we're doing transplant and using TBI. Next slide, please. These are the numbers which are put there. The grade 3 and 4 was the toxicities. Grade 4 was fatal. So you saw 11 of them who were fatal, had a heart failure, and then 2 of them had arrhythmias. The others were primarily arrhythmias, which was not, life-threatening and fatal. So this was the subset in this mortality, which was described in the study. Next slide. Now, haploidentical, I had to talk about it because of the numbers which are going up in our country. So this is some data of cardiotoxicity in the aplastic anemia subset who underwent haploidentical transplants. Next slide. So this is a breakup of these patients. So of the 200 odd patients, 12 of them had grade 3-4 cardiotoxicity. Clearly, there were more number of adults here. Not too much difference between the severity. If there was previous usage of cyclosporin, there was a higher incidence, possibly because of hypertension related issues. And then again, ferritin, not much of a difference between the two subgroups. Next slide. So what they finally, when they did their analysis, they found that the significant difference here was when you were using a higher dose of cyclophosphamide. So the 1.8 gram per meter squared cutoff seemed to have some role when clearly when you had, a dosage which was higher than that, about 75% of those patients were the ones who got that kind of dose in the ones who had the cardiotoxicity. So this was what came out of this. And obviously, if there were more comorbidities and you had a higher ECOG score, then again, you obviously had a higher incidence of trying to develop cardiotoxicity. Next slide. So this was the gist of it, and they looked at echocardiographic findings in these, and they came up with some parameters. I think we discussed this partly. The left atrial dimension, the left ventricular dimension, again clearly highlighting the systolic damage, which is more important than diastolic dysfunction. ECG changes primarily, which are arrhythmias, are the ones which are highlighted in this study. Next slide. My last few slides would be on cardiac complications, even in the RIC transplants. So when we tend to say that we're doing reduced intensity conditioning, less side effect, less toxicity, but still remember that we could still have cardiotoxicity. Next slide. So in this subset of about 278 patients who underwent RIC transplants for hematological malignancies, they looked at a subset of people who had received anthracycline of more than 400 mg per meter squared or had an EF of less than 45% and categorized them as high risk subset of patients and compared them with the others which were not high risk. Next slide. And the conditioning which they received was flu and TBI, 2 gray with BU. So this was the RIC conditioning protocol which was used. Next slide. And in these 278 patients, 25 of them developed the cardiac problem, which was primarily arrhythmias. 12 of them went on to develop an MI with congestive cardiac failure, and 19 of them had recurrent arrhythmias. 7 of them had resolving of their arrhythmias. Now, when they just grossly compared the two groups, clearly their outcome, when you looked at the day 100 mortality rates, was definitely higher compared to the control arm, which did not have any of this. So obviously the cardiotoxicity is contributing to your mortality outcomes there in one of the two ways. It could add to potentiating other trouble, or it could be individually by itself adding to the morbidity. Next slide. I think I should be ending there. And basically the gist of this was that those risk factors which they identified as the anthracycline dose and the pre-cardiac echo EF less than 45% was the kind of risk factor which was associated with the highest cardiac complications, 90% and 70% each. So this is something which we need to look at, and clearly this would put our patients at a high risk category, and we need to be more careful if you're taking such a patient for transplant. I think that's my last slide. I'll end there. So to comment that these are the crucial things which we need to address when you're looking at patients who go for transplant: the cyclophosphamide dose, previous history of anthracycline use. If you're using TBI, again, there is a higher risk there, and then the baseline EF. But again, I think after discussing with the cardiologist, if the EF is normal and they're having a normal ECG, there's really a very, no clear way to predict who would go on to develop a problem. You can only pick it up early by monitoring regular ECGs and echoes. Thank you.
Thanks, thanks, Sharad. One of the questions in the chat box was regarding the cardiotoxicity of melphalan. Now, any drug can cause, but what is your experience or opinion on the cardiotoxicity of melphalan?
Yeah, so I've actually looked this up, Naveen. So clearly they do not, list out and say that this is the cardiotoxicity described with this. But in our own experience, I've had patients where we've used it in myeloma, both at 140 and at 200. And we've had a patient who's had an MI, and then somebody who again dropped his, EF post about day 10-ish. So even though you don't have this mentioned clearly, it is there in the post-marketing surveillance that this data has been coming up, that it can produce, even though it is rare. So when it is used both in the myeloma or in the flu-mel protocol, you need to be aware, especially if there's a predisposing factor, this can certainly add to a toxicity due to the conditioning, whatever you used.
Sure. There's one question for Dr. Sethi. If you had to do the GLS as well as the look at the ejection fraction, and if you find that the GLS is low while the EF is normal, would you recommend some sort of cardioprotection for any patient who's going to receive some sort of chemotherapy which can increase the risk of cardiotoxicity?
So if the GLS is compromised with a normal ejection fraction, and if the oncology friend comes back to us saying that, this patient has had maybe an anthracycline in the past, even if the dose had not been very high, and, as mentioned just now, that in the BMT conditioning, he had maybe a drug like cyclophosphamide with risk factors like diabetes, hypertension, dyslipidemia, we would definitely advise them to be put on this combination of ACE inhibitor and carvedilol, because in our own cardiology practice, these are very, very safe drugs. I mean, we don't see any real, side effects, even when patients have been taking them for many, many years altogether. And if it does help in preservation of LV function and in reduction of cardiac complications, down the line, then I think that's a very, very good strategy, and I would definitely advise that.
Sure. The only problem, Dr. Sethi, is that, when you do transplant, you are also on some of the drugs, especially the calcineurin inhibitors. And, they have some drug interaction with both the ACE inhibitors as well as carvedilol. So sometimes it's a catch-22 situation in which you need to protect the heart, but the interaction between some of the drugs which we use in transplant becomes a bit difficult to then take that calculated risk and decision.
No, I agree with you. I mean, that is something that would be beyond my purview. But yes, if a recommendation is sought from us, I would say yes. We would definitely, we are using GLS now, in a series of our patients who have pacemakers, because pacemaker induced LV dysfunction is a very, very common thing that we are seeing. And if the patient has some symptoms of congestive heart failure, but he has preserved ejection fraction, we do look at GLS in these patients, and prophylactically put them on ACE inhibitors and beta blockers to prevent decrease in ejection fraction as they continue to pace their ventricle. So that is a subset that we have seen works when the GLS is low, but yes, as far as the oncology drug interactions are concerned, I probably would not be the right person to answer that question. But yes, if a recommendation comes to us, we would certainly say that yes, should be given.
Thank you. I don't see any further questions in the chat box. Is there? I think there is from Vivek. Yes, do all patients need pre-transplant cardiology review and any risk stratification in BMT? Maybe Sharath, you can take it, and Dr. Sethi can help you with it.
Yeah, Naveen, I think, especially the ones who are over the age of 40, or if they have comorbidities, hypertensive, diabetic, we tend to send them to get a cardiology opinion. That's what we've been doing lately. After having burnt our fingers in the past, it kind of helps us just to at least get them seen by them as baseline. So they would go through an ECG and echo for sure. And if they have any such doubts, they would further evaluate them before sending them back and giving clearance for BMT. Now, whether we can risk stratify them, I think we've already discussed that. There's no clear-cut indicator if you had normal ECG echo, whether you can use GLS probably, and along with their comorbidities, and whether we would do something different about using the cardioprotective drugs. But again, we've got multiple of our own drugs. All of them have their own toxicities. You're going to club them together. So that's going to be individually patient-based. But this is something which we've routinely started.
Yes. Any comments from Dr. Sethi regarding this?
Yeah, I'd just like to say that that's a very good, strategy. That if as Dr. Sharath, I think, had mentioned that if you have an elderly patient, maybe 40, 45 years with some risk factors, it'll be good to run them by a cardiologist. So that at least, in the kind of milieu that we are practicing these days, for all you're trying to do good to the patient. But 6 months down the line, if he does drop his ejection fraction, the patient can come back to you and say that, why was I not sent to a cardiologist before you did my BMT? So looking from that medical legal aspect as well, I think it's a great idea to run them by. And, we are not going to be doing a major investigation. It's going to be an ECG echo and probably a treadmill test or a stress echo. And if in case there is abnormality, then you can escalate to maybe doing a coronary angiogram or a CT coronary angiogram to rule them out. But I would certainly say that it's a good strategy and would remain in good state for the patient and for the oncologist as well.
Sure. So if there are no further questions, comments, I would like to thank everyone, and especially Vivek, for giving this opportunity. Over to you, Kashish.
Thank you so much, sir. Thank you to all the participants for a wonderful session. I now request the Asian Cardio Oncology Society Honorary Secretary, Dr. Vivek Agarwal, to please give the vote of thanks. Over to you, sir.
Yeah, I think we had a really wonderful meeting today. The icing on the cake was Dr. Devi Shetty himself coming to chair the first session and enlightening us all with his good words. A really good first session where Dr. Arjun Ghosh told us about CAR T cell treatment, and we are actually getting into this with some centers in Mumbai as well as in Kolkata, really developing our own indigenous CAR T cells. So we need to, learn about the cardiotoxicities also. A very good session by Dr. Randeep Singh. I think he did a very good job on chalking out the cardio safety issues regarding the supportive care measures that we take in oncology. And really a wonderful case presentation in the end by Dr. Prashant as well as Dr. Rahul, and wonderful excerpts by Dr. Sharath as well as Dr. Sumit Sethi, and wonderfully moderated by Dr. Naveen. I thank you all for your participation, and I would request you once again to please take membership of our Asian Cardio Oncology Society. I think we have been not, if not really very successful, but probably successful in conducting these meetings. There have been 7 of them that we have done, and today we conclude our first conference, the 7th series. And I think we all learned a lot in these past 7 weeks, and we will continue learning under the aegis of Asian Cardio Oncology Society. We would definitely are planning to come up with monthly meetings and probably come up with more varied topics so that we don't bore our audience. Also, we are looking forward to involve our younger oncologists as well as the residents to participate in these meetings. And definitely the plan is to collaborate to come up with our own Indian studies regarding these cardio-oncology issues. Once again, I thank you all for your participation, and wishing you all a good night. Thank you.
Thank you so
Vivek,
much.
Vivek, you have been very modest. You've done a fantastic job, and there is so much to do in cardio-oncology. So in South Asian Journal of Cancer, we are going to have a separate cardio-oncology section, and we welcome manuscripts from everybody who's working in this.